Hello, my name is Barbara Vanderpaul and I'm speaking to you today from my office at the University of Alabama at Birmingham School of Medicine. I've been involved in STD Laboratory Diagnostics for more than 30 years, and so it's my very real pleasure to talk to you today about the 2014 CDC Guidelines for Laboratory Diagnostics of Chlamydia and Gonorrhea that came out in March of this year. Of course, I'll start with disclosures, and this is a list of sponsors from whom I've received research or consulting support over the last 2 years. I've organized the topics that I want to go over with you today to talk about why we're screening, because I feel like sometimes we forget that chlamydia and gonorrhea are still very relevant infections, and I want to provide you with some up-to-date data to remind you that they're actually quite important. I do then want to talk to you about how the guidelines were developed, what the recommendations actually are, and then how these might impact both clinical practice and laboratory practice. So I'm going to start by telling you things that you surely already know or you wouldn't be tuning into this webinar. So chlamydia and gonorrhea are still the #1 and #2 most commonly reported notifiable diseases in the U.S. I've shown here the numbers that CDC estimates in terms of the numbers of cases that were reported in 2012. And what you see is that salmonella is actually the 3rd most common notifiable disease, and it occurs about 30 times less often than chlamydia and gonorrhea. So actually quite important. I'm sorry, that was 300 times less often. So we're talking orders of magnitude of difference. So these are very, very prevalent infections. But of course, I think we all know that prevalence really isn't sufficient to warrant a control program. We don't have control programs for the common cold. And similarly, even though they have consequences of infection, we don't have control programs for herpes simplex virus, nor do we have a control program for papillomavirus. Part of the reason for that is because we don't have effective strategies for preventing transmission of those, unlike chlamydia and gonorrhea, where we have very effective treatment and cure strategies. So this is actually some information that was taken from an article by Hoots and colleagues about whether or not Trichomonas vaginalis should be a notifiable disease. But I think that the points that they raise in this particular article about the 7 things that you have to be able to answer yes to in order to have a notifiable disease also apply to whether or not we should have a control program. And by having a control program, a piece of that is that we should actually have a screening program, and that means detecting asymptomatic infections. So I'm going to talk to you briefly about the 3 items that I've underlined here: frequency, prevalence, health disparities, and the costs of negative outcomes, to remind you why chlamydia control is particularly important. So the first topic there was frequency and prevalence, and I think many of you again may have seen this, and this is just suggesting that the chlamydia rates continue to increase in the U.S. These are data from 1992 to 2012, so we have more than 30 years worth of data here, and we see steady increases in the rates of total chlamydial infections. We also see specific rates, increases in the rates among women. So it's very common that people say, well, these rates go up because we have improved assays. And that's very, very true. We're much better off than when we only had culture and non-culture but non-amplified diagnostics. We catch many more infections with these tests. However, those tests were mostly introduced in the mid to late 1990s, which you can actually see here, the mid to late 90s. We still see increases after that time point. Another thing that people say, well, these rates are increasing because, in fact, we're increasing our testing overall. That is one of the problems with these data, are they don't have good denominators. So we don't actually know the number of patients that are screened in order to get these rates that we see here. So while that's a reasonable argument, I think the GC data actually are fairly convincing to demonstrate that the chlamydia rates are going up. If it was just a result of improved diagnostics and improved screening coverage, the GC rates should be going up at the same time the chlamydia rates go up. And we've not seen that at all. You can see that GC has essentially plateaued at about 100 cases per 100,000 people per year. And these are actually data from British Columbia, where they have National Health Service, and so they can look at all the data from British Columbia. And Bob Brunham's group did this analysis back in the mid-2000s, and so he took data from 91 to 2003, and he showed steadily declining rates of chlamydial infection after the onset of a control program. But what you see is after about 1996, the rates go dramatically up, and they actually, in fact, get almost back to where they were before the control program started. Similarly, in other countries, and this is a multinational data set analysis that was done by Nicola Lowe and colleagues, you can see steadily increasing rates of chlamydia throughout the world, and these are countries from Western Europe, Australia, and New Zealand. And so this is a very, very consistent pattern, that the rates of chlamydia plain and simply are going up. So the next point on that bullet list was, are there health disparities? And again, I think that's pretty obvious, and most of us are familiar with that information. We know that Black people in the U.S. suffer disproportionately from sexually transmitted infections. But these are data from the National Health and Nutrition Education Survey that is a nationally representative population-based survey which estimates the overall prevalence of disease in the population. And this actually shows a decline in chlamydia rates among Blacks until about the mid-2000s, but in fact those rates are going up. And you can see that not only are the rates going up, but the disparity is actually increasing as well. So that gap is widening rather than becoming reduced, which suggests that we need to have improved diagnostic options to reach more people, and particularly people of color. So the two charts that are on the left here show you the rates in Blacks for both chlamydia and gonorrhea, and of course they're substantially higher. You see at least a twofold increase for Blacks compared to any other racial group for chlamydia, and you see about a 4- to 5-fold increase for gonorrhea. But not only are Blacks at higher risk for these sexually transmitted infections, but people in the Deep South, which is where I'm currently working, also have higher risk of infection, which we can see with the red arrow in the chart on the right. So we have high prevalence, we have health disparities. Do we have negative health outcomes from chlamydial infections? And of course the answer is yes. We've known for many, many years that untreated infections can lead to pelvic inflammatory disease, ectopic pregnancy, and tubal factor infertility. This is a really nice set of data from Price and colleagues that was a meta-analysis of all the very carefully controlled, randomized controlled trials that actually looked at PID as an outcome and chlamydia as a risk factor. And from this meta-analysis, you can see here from the different studies, you can see the different amounts of PID that resulted following chlamydial infections, and taking that into a meta-analysis, the authors estimated that a woman has about a 16% chance of developing pelvic inflammatory disease following a chlamydial infection. Now, these were chlamydial infections that were identified and treated, so these are not long-term, multi-year, untreated infections that led to adverse outcomes, but rather infections that were actually identified and treated. So this is pretty substantial. And in fact, their mathematical modeling estimated that annual screening for chlamydia could actually reduce the rate of pelvic inflammatory disease by 61%, which would be a substantial health savings. Similar data come from England. Here is the rate of definite and probable PID diagnosis in England from 2000 to 2008. Now 2000 was when they started their national chlamydia control program in the UK. And what you can see are declining rates of PID, and even more importantly, what you can see is that the rates are declining the fastest in those age populations where screening is recommended for routine screening, not based on any risks or signs and symptoms. Again, from that multinational data set that Nicola Lowe's group had analyzed, here you see somewhat of a different pattern where you see decreases in the rates in some countries, including the Western European countries. However, you see flat lines in some countries like the Netherlands shown in red and Sweden shown in yellow. Of course, in both of those countries, both the chlamydia rates and the PID rates are quite low, and so perhaps that's why there's less of an impact with chlamydia control programs. Interestingly, what's shown here in green is the data from New Zealand. New Zealand has the most recently implemented chlamydia control program of all of these countries, and so potentially hasn't had time yet to have a noticeable effect on PID rates. So that certainly bears watching in the future. Similarly, they have data for ectopic pregnancy rates, but what's interesting here is we don't see the same clear-cut pattern. In some countries, the ectopic pregnancy rates are going down over the time period that chlamydia control has been available, and in some rates they're flatlined or even possibly going up, as we see in the Netherlands. But going back to the data from British Columbia and Bob Brunham's group, they did an analysis with the actual PID rates a couple of years after they had done their initial findings showing that the rates of chlamydial infection were going up. So here in blue, you see the increasing rates of chlamydial infection, but in red, you see the decreasing rates of pelvic inflammatory disease. So even though we're not being effective in actually stopping chlamydial infections, we may be effective in capturing them earlier and thereby avoiding some of the downstream consequences of those infections. The data are somewhat less clear with ectopic pregnancy, which seems to go down slightly and then rebound again slightly, but the numbers are quite low and it's unclear how much noise is in this particular analysis. So when we put all this together, I think that what we say is that case rates are rising. It's factual, it's not artifactual, in both women and men. This is not explained solely by improved testing technologies. And we still have substantial health disparities that we really need to focus on improved methods for identifying those cases and treating those cases more rapidly. However, the good news is that PID rates are decreasing. Ectopic pregnancy is somewhat more complicated, but it looks like, at least in terms of the PID rates, which is the most substantial cost burden, health economically speaking, we are having an impact. And therefore, control programs are likely warranted for chlamydia. So that means that we need treatment guidelines, or we need screening guidelines. And in the US, the screening guidelines are actually described in the treatment guidelines, which makes it a bit of a misnomer. But what you actually have recommendations for, on the right I've put a chart that shows you the age probability of ever having a chlamydial infection. You can see that for women, there's actually a reduction in benefit for screening in older women because the highest probability of being infected is actually when you're below 20, and that probability declines sharply by the time you're 25. For men, there's no easy, clear-cut solution to say there's an age group. So in fact, we have screening recommendations for urogenital testing for all women who are 25 and under. Some of the guidelines, not CDC guidelines, but other groups recommend less than 25, so that number is a little bit variable, but in that age range. There's also recommendations in the CDC guidelines that all women and men who report risky behavior be screened at least annually or when they attend clinic. Now that risky behavior may be a new partner, partner change, a high number of partners, intravenous drug use, other high-risk behaviors that have been typically associated with STD risk. The guidelines also recommend that men who have sex with men be tested at least annually using genital testing, so this is usually a urine or urethral swab. The newest iteration of the treatment guidelines, which came out in 2010, recommend that extra-genital screening be performed annually for all men who have sex with men. So this covers ano-rectal screening as well as oropharyngeal testing. So part of, again, going back to the data from British Columbia, because they have national health care data, it's very broadly applicable because it covers the entire population of British Columbia. So here they were able to look at the prevalence rate in British Columbia, which you can see is less than 1.2%, pardon me. And the rates in the US are estimated to be about 3.4%. So their rates to begin with in the general population are much lower than those in the US. And you can see that a vaccination with 80% coverage might eliminate chlamydial infections within 5 years after instituting that program. But what you also see is when we look in green, mathematical modeling suggests that you'll have a sharp reduction in the number of cases after a screening program is implemented. But over time, the number of cases will rise. And this is the data that I've just shown you. It matches this chart fairly well. But what's worth noting is that in this mathematical modeling was predicated on the assumption that we're covering 80% of the people that we've determined are appropriate for screening and control efforts. So in the US, we've had these screening recommendations since about 2000. So how are we doing in terms of coverage? Well, this is the 2012 data from the HEDIS review of medical practice plans in the U.S. And unfortunately, what we see here is that in commercial HMOs shown on the left, we see that the coverage doesn't even reach 50%. and commercial PPOs, it doesn't reach 50%. The only groups that reach 50% are those that are federally assisted and covered by Medicaid. Unfortunately, you will also notice that the blue bars are always less than the orange bars, and the blue bars are the younger population. So these are the 16 to 20-year-old women. Now, these data are actually showing you the proportion of women who actually made a visit and were eligible for screening but weren't provided with the service. Whether they declined it or it wasn't offered isn't known. But one of the things that this may reflect is actual discomfort on the part of the provider discussing sexual health with their patient, and discomfort on the part of the patient in asking for sexual health screening. So both of those things may actually have an impact on explaining why we're not actually able to meet the coverage that we need to meet. So that leads me into the Laboratory Diagnostic Guidelines, because I think that with the new guidelines, we can see that there are actually ways that we can start to increase our screening coverage and hopefully provide excellent quality data for practitioners to make clinical decisions based on. So I do want to start for a minute by talking about how the guidelines were developed, because I think it's actually important to understand what went into this process. So the 2014 guidelines are the first update since 2002 for the Laboratory Diagnostic Guidelines. Obviously, technology has changed immensely since 2002. We have so many more opportunities and options. So that's part of what I want to talk to you about in terms of how this impacts what you do in your clinical practice and in your laboratory. This entire process started in 2008 with an intensive literature review. We partnered with librarians at the National Institutes of Health who actually helped us do our data review and pull literature not only from published articles, but also from peer-reviewed abstracts at meetings, because we really wanted to get cutting-edge data that might not have made it into the literature quite yet. We put these articles and these abstracts into categories, and some of the categories included comparisons of assays. So head-to-head comparisons of any different assays that we could find, old assays, new assays, upcoming assays. We looked for articles and abstracts that talked about evaluations of extra-genital specimens, because we knew that was one of the screening guidelines. We felt we had to provide some data and some recommendations to help laboratories support those screening guidelines. And finally, we looked for evaluations of self-obtained specimens, and I'll talk a little bit more about self-obtained specimens in a few minutes. So in January of 2009, we met as a group, and we finalized our recommendations for the guidelines. So obviously, from January of 2009 to March of 2014, it was a rocky road to publication. It took us quite a bit of effort, and I want to share with you one of the reasons why we had trouble, and I'll get there in just a minute. So the first of the recommendations for the laboratories are, what are the class of tests that's recommended? Well, this is a really easy answer. It's NATs, NATs, NATs. So nucleic acid amplification tests are the way that everybody should be testing for chlamydia, gonorrhea in any type of practice or setting. Really, that's the end of that whole conversation, but I'm going to keep saying it because it's really quite important. For the first time, we actually have language in the recommendations that specifically says the following tests are not recommended for routine use, and that includes DNA probes, ELISAs, most of the rapid tests that are currently available on the market. So non-amplification tests are specifically discouraged. It's not just that they're not the optimal type, they really shouldn't be used because they don't provide high quality results. Another important factor is that in the guidelines we specifically mention that there's no distinction for screening versus diagnostic testing. Now you'll remember that chlamydia and gonorrhea infections, especially in women, may be asymptomatic the vast majority of the time. 60 to 70% of infections are likely asymptomatic in women. Gonorrheal infections in men are rarely asymptomatic, but in women they may be, and chlamydial infections in both men and women are usually asymptomatic. Therefore, we really need screening practices that are not waiting on people to come into the clinic, because we're talking about people who don't have signs or symptoms that cue them to access health care. Now, of course, when you have any individual coming in to a patient care setting, their symptoms may require some sort of different workup than the generic requirements that we put out in the recommendations. So just recognize that there may be other options. There may be times when culture is required, particularly for GC, and I'll talk about that as I go through. But as a general overarching statement, nucleic acid amplification tests are the way to go. It doesn't matter if patients have symptoms or don't have symptoms. These tests work perfectly well in either case. Okay, so now I told you I would talk to you about why we had problems getting these recommendations published. And in fact, the problems were it's quite difficult to understand exactly what the sensitivity and specificity estimates are for any of the tests, for chlamydia in particular. So chlamydia culture is notoriously insensitive. I've shown here a couple of graphs that show you what the estimates might be for a test when it's compared against culture. And so what you see here is when we look at a new test and estimate it against culture, and you'll see that I've mentioned GP here just as a name of a test that is actually no longer available, but just for comparison's sake, this test was estimated to have a sensitivity of approximately 78% when it was compared to culture. But when it was compared to other tests that were nucleic acid-based tests, then its sensitivity dropped to closer to 70%. So the reality is that if we're comparing something to culture, which sensitivity may be as low as 60%, if that new test, it says, oh, well, it has a sensitivity of 80% compared to culture, well, that may mean that it's missing the same 40% that culture missed, and it may be as low as 48% sensitivity. So for that reason, non-amplified tests are plain and simply no longer recommended for use, despite the sensitivity estimates that might appear in package inserts. So in 2002, we were still using what we call now the tarnished gold standard, where we were using culture and perhaps one other non-amplified test to try and determine what the true infection status of an individual was. So the 2002 guidelines were based on these early evaluations, but now in 2009 we recognize that those package insert data are largely meaningless because they were compared against a poor standard. So when we use a poor standard, we can grossly overestimate the sensitivity, as I just mentioned. We can also grossly underestimate the specificity. So, for example, if we're comparing to culture, and culture only identifies 60% of infections, if we used a NAT test that identified 100% of infections, we might think that extra 40% were false positives. So therefore, there was a lot of concern in the early days of amplified testing that specificity was poor. In fact, we have so much more data now than we did in 2002 that we actually know that this is not the case. So in 2002, the guidelines recommended confirmatory testing of positives if the positive predictive value was below 90%. And the positive predictive value in any population is almost always below 90% because that's just the reality of the populations that we test for something that has a 3% population prevalence. Now, we have next generation tests for almost every assay that's on the market now, and those tests have improved both sensitivity and specificity. And based on all the data that were available that we looked at in our evidence-based review, no confirmatory testing is recommended now for any of the NATs. So if you have a positive result, action should be taken on that positive result, and no confirmatory testing should be ordered. I just want to show you a little bit of an example of some of the next generation assays. And all I'm trying to show you in these figures is that there's actually quite a bit of waffle room when you look at the confidence intervals for any of these tests. You'll see they're quite large. So sometimes you'll see that the actual point estimates vary widely, but the confidence intervals are almost always overlapping. So it's quite difficult to say that there's a real difference in sensitivity between any of these assays. This is for female specimens in a study that we did in 2000 with one particular vendor. Here's the same data for gonorrhea from female assays or female specimens. And again, you see that there are very large confidence intervals, and the point estimates vary somewhat, but the reality is that the sensitivity is always in the high 80s or high 90s. Another way to look at it that I like to just put together so that I can see all the data and make my own decisions is we can look at a Venn diagram where in the middle you see the positives that were identified by all of the assays, and in the boxes that are a little bit darker you'll see results that were positive by 2 of the 3 assays used in a clinical trial. And then out there by themselves you'll see those positives that were positive by only 1 assay. Now this type of diagram doesn't help you determine if these are true positives or false positives. It's just showing you that when you really look at it, the vast majority of positives are detected by 2 or 3 of all the assays. And so we actually have very, very high confidence that these assays are performing quite well. So then if we look at the recommendations specifically in women, again, I'm going to say it over and over, NATs are the class of tests that should be used. We did make a recommendation about the sample type, and for women, self or clinician-collected vaginal swabs are the recommended sample type. Endocervical swabs are acceptable when a pelvic exam is indicated, although I would throw out to you the fact that vaginal swabs can be collected before a patient ever actually interacts with a clinician, thus saving the clinician's time. If a provider needs to do a pelvic exam and needs to actually make some observations, there's no reason they shouldn't do that, but that vaginal swab can already be sitting and waiting to go away to the lab, and it doesn't take any of the clinician's time away from doing patient management to collect that specimen. First catch urine is acceptable but may miss up to 10% of infections. Now this is language that's taken directly from the recommendations. Based on those charts that I just showed you, you could see that there were really wide confidence intervals, so we don't see statistical differences, but urine tends to be low in general terms, in terms of sensitivity. Please note the last line here that endocervical swabs for GC culture are clearly warranted if one suspects that a patient is a GC treatment failure. So you should collect that sample so that susceptibilities can be run. Now here's some of the data that were used or similar to those data that were used when we determined which sample type to recommend. This is from a particular study that was done in 2012 and published last year, where you see that the sensitivity of the vaginal swab was highest, followed by the endocervical swab, followed by the female urine. And you see chlamydia in blue and gonorrhea in orange. And we see this pattern just repeatedly. Here is a compilation of studies. I've shown the studies they come from in the line that says adapted from, and I pooled the data because I actually had the raw numbers from these particular studies. And you can see that clinician and self-collected vaginal swabs, actually the self-collected vaginal swabs almost always perform slightly better than the clinician-collected. Endocervical swabs, again, slightly lower, and urine specimens, again, slightly lower for women. But you also see the error bars on here, and so you can see that these are not statistically different. So if I keep saying these are not statistically different, is there really a meaningful difference here? And I want to say that this pattern has been observed over and over and over again, where we see vaginal over endocervical over urine, and in fact all 3 of those sample types are somewhat better than liquid-based cytology media. This is a consistent finding spanning more than 10 years with data from every major diagnostic platform. And so a meta-analysis of this clinical trial data would be useful, and that's a project that I've recently started. So hopefully we'll be able to get raw data that went into FDA submissions for these platforms, and we can actually maybe pool those data and determine if there really is a statistical difference. And clinician and patient-obtained vaginal swabs are obviously equivalent in quality, but there may be other advantages to patient-obtained sampling. For example, it's been shown that when patients are involved in their own healthcare making decisions, they tend to be more active and more engaged in the process and stay engaged in the process, which might mean that they're more likely to come in for treatment, although we don't have data to that effect. So it may be worth saying that if we can have women participating in their health care by collecting their own specimens, then they become active participants in their own sexual health maintenance. So we'll move on to the recommendations for men. So what are the recommendations? Well, obviously NATs are the class of diagnostic. First catch urine is the recommended sample type. We didn't see any evidence in the data that urethral swabs ever have improved sensitivity. That was for symptomatic and asymptomatic men, when we pooled all the data, we just didn't see any difference. In fact, urethral swabs may provide a disincentive for asymptomatic men to be tested in the future. So that was why first catch urine was the recommended sample type. Do remember that a urethral swab for GC culture is clearly warranted if you suspect treatment failure. Again, just a bar chart showing you the point estimates and the confidence intervals. You see urethral swabs up on the top, and their point estimates are slightly lower than the urine estimates, which are on the bottom part of the chart, and this is for chlamydia. But again, those confidence intervals all overlap, and these are the data for gonorrhea, again, with the urine at the bottom and the urethral swabs up at the top, and no significant differences between those sample types. Now, extra-genital testing. So again, obviously, NATs should be used for rectal and oropharyngeal samples. As I mentioned earlier, the treatment guidelines recommend annual screening for men who have sex with men. Now, studies have suggested that screening everyone in some clinical settings may be valuable because reported behavior may be underestimating receptive anal intercourse. I haven't found this to be the case in the clinical settings that I've been involved with, but it's something that's certainly worth considering depending on the clinic structure and the population it serves. Now, it's really, really important to remember no assay has FDA clearance for these sample types. Not a single assay on the market currently has a claim for rectal or oropharyngeal samples. My laboratory has validated several assays, and we will continue validating newer assays, and we have not seen any inhibition or any other reason to suspect that any of these assays are not useful for rectal and oropharyngeal testing. I did want to share with you just a little bit of data for those of you who don't routinely think about extragenital testing. In fact, looking at data from the Indianapolis STD clinic where I was until just recently, these are data from 2011 where we have on the top line the rates for genital chlamydia, which you can see in men was about 19%, in women about 14%. But if you go down a couple of lines, you see the rates for rectal chlamydia. And this is among people who said that they were having sex with men or receptive anal intercourse. 17.2% of the men who reported receptive anal intercourse were positive for chlamydia in the rectal sample. The GC rates aren't quite as astounding, but still 6.6% in the genital compartment and 2.3% in the rectum. But a different way to look at this is to compare how many cases we would have identified, because we really care about treating people. We really don't care exactly how many different places they have it as long as we've captured that and we've treated them. But unfortunately, what we find, if you look at the far left-hand bar, in men, the majority of infections, men who have sex with men here, the majority of infections were actually identified in the rectum. Only 9 of these 113 infections were actually found in both the rectum and the urogenital compartment. So these are very localized infections, and if you're not testing the rectum, you're missing the vast majority of cases of chlamydia among men who have sex with men. This is true for gonorrhea, but on somewhat less of a scale. You'd be missing about 40% of the infections if you weren't doing rectal testing and you were only doing genital testing. But of course, our test can test both chlamydia and gonorrhea from the same sample type, so we can really maximize our case finding by running those highly sensitive tests on both sample types. For women, we see that co-infection is much more common, or infection, I should say, in both body sites, both the genital samples and the rectal samples, as well as the genital samples and the oropharyngeal samples, which I'll show you on the next slide, for chlamydia and gonorrhea. So there may not be as much bang for your buck in testing women, even those women that report rectal anal intercourse, because they may actually have enough spread between the genital compartment and the rectal compartment that you can identify it with a genital sample. Now, here are some confirmatory data that came out of Birmingham, where I am now, and this was published in 2009. And here again, you see that you would miss 80% of the infections if you were only testing genital samples from men who had sex with men. You would also miss about 60% of the rectal samples, or the infections of GC, if you weren't doing rectal samples. And in women, there's much less bang for your buck again. Now, the oropharyngeal, you're catching about 2/3 of the sample population that's infected from any one sample type. So you'll capture about 2/3 of infections doing just an oropharyngeal, or about 2/3 doing just a genital. So if you want to pick up that extra 30%, you probably need to be doing an oropharyngeal sample as well. So just to summarize this, and I think I've said it enough times, NATs are the class of sample or the class of testing that you should be doing. There is no confirmation required. There may be circumstances where you feel it behooves you to do confirmatory testing, but in that case you're going to have to think clearly about what the best strategy is for using a different platform, using something with different targets, using a different laboratory, collecting a second specimen, etc. The recommendations in terms of sample types are vaginal swabs for women and male urine for men. NATs are good, work very well for rectal and oral pharyngeal samples, but each laboratory has to validate this locally. And so this is an area where clinical services have to work carefully with their local laboratory to make sure that they can access this service, and to explain to their local laboratory that they need the laboratory to go into the cost involved with this validation process. It's not really quite simple. As a general rule, if you want duplicate specimens for a validation process, that's difficult for rectal specimens because not many people are willing to give you multiple samples. Culture capacity does need to be maintained, and we kept that language in the guidelines because especially GC testing. We particularly need to make sure that we do have isolates so that we can do susceptibility monitoring and look for drug resistance in GC. There are some cases of both chlamydia and gonorrhea, child sexual abuse, where culture may be appropriate, but the recommendations for sexual abuse cases are still NATs, not culture, because the specificity is actually quite good for nucleic acid tests. And now I want to spend the rest of the time that I'm going to talk with you talking briefly about how these assays may improve both clinical services and laboratory processes. So the first thing is that these assays perform so well now, and the specificity is actually so good that you actually have increased case finding, and you have a reduction in the false positive result rates. So in other words, clinicians can feel really comfortable when they talk to their patients. They should be very, very certain that they actually do have positive results. And this is important because obviously with STIs there's so much stigma and there's so much social consequences to an infection that we want to be really certain that we're giving the best quality results. We also want to make sure that we're identifying infections. We don't want false negative results either, because that can lead to the consequences we're trying to avoid, such as pelvic inflammatory disease. Patients can now collect their own samples before seeing a clinician. I think this is really key in a lot of ways. Remember that one of the things that I've been talking about is the fact that we need to be able to reduce our health disparities, and one of the ways I think that we can do that is by making this much more normative. So instead of people feeling like they're targeted and they were asked to be screened for an STD because of their color or because of certain behaviors, now all of a sudden everybody's doing it. When you go into the bathroom, you provide a urine sample, you provide your vaginal swab. Then, when you go in and see the clinician is doing what only a clinician can do, and that is interacting with the patient, finding out what's going on with the patient, and really helping them with their needs. But that specimen for the laboratory is already sitting there and waiting and labeled. And again, as I said earlier, even if a clinician needs to go in and have a look around, there's no reason that they can't do that just because that vaginal swab is already sitting waiting for STD diagnostics. They can still do as full a workup as they need to do. But not everybody will require that workup. And particularly when we're talking about trying to normalize screening so that we're accessing the testing for each woman every year the way the guidelines suggest, then those women that didn't need a pelvic exam don't have to have one just so that they can adhere to the screening guidelines. I would also mention here that we probably don't want to use the urine that's collected during that process because these are often clean catch midstream urines. And since urine already has a lower sensitivity than other sample types, particularly vaginal swabs, when you consider going from first catch to midstream, you're reducing that sensitivity even somewhat more, although we don't know the exact magnitude of that reduction. So again, that urine specimen is not ideal for chlamydia gonorrhea testing. For people that are doing Pap testing and want to use liquid-based cytology, that's still a possible option. It's still in the guidelines, so certainly that test can go. But if they have the patient collect a vaginal sample before they've ever gone up onto the table for their Pap exam, and since Pap exams are now being done only once every 3 to 5 years, depending on the patient's history, we can still have them coming in every year for their STD screen because, again, it's normative. We're not targeting people. We're not making people feel different or stigmatized because we're asking them to collect this sample. It's just the routine. My goal is in life is that 10 years from now, if it can be as normal for a woman to go in and collect a vaginal swab at any reproductive health care visit just the way she would go in and provide a urine, think how far we would have come and think how much better we will be doing at adhering to those guidelines. The tests that we have now that allow us to use vaginal samples allow us this opportunity to move the field forward in that way. Finally, extra-genital sampling may really improve case finding, and this is particularly relevant for any practices that serve predominantly men who have sex with men, whether it be an HIV clinic or whether it be a well men's clinic, and you are just trying to do screening and prevention. It's really important in order to find the infections that are out there and that are asymptomatic that screening of extra-genital sites be done. I will say also that I've done a number of studies where men have collected their own rectal samples, and in fact they tend to prefer that to having a clinician do it because it's a somewhat humiliating procedure. But men don't mind just providing their own sample, and you can use that sample because the tests that we have today are so very, very sensitive. But it's not just the clinic that benefits. The lab obviously benefits too. All of the next generation assays are so much vastly improved compared to the assays that we started with in the 90s. This is a study that I did while we were still at Indiana, and we looked at the turnaround time to results for a number of the assays that are on the market. This doesn't have data on the Hologic Panther because we didn't have that assay at the time, but it has the Roche 4800, the Hologic, or BD Viper, excuse me, the Hologic Tigris, and the Abbott M2000. And what you can see is that these assays predominantly have turnaround times that are less than 6 hours. The Roche, I have up here a little red bar because if you're using the second version of the Cobas 4800, it's extended a little bit from a 4-hour to about a 4-hour and 45-minute assay. But what's really important here is to look at the dark gray bars, and what you'll see is walk-away time, and particularly uninterrupted walk-away time, where you just leave the instrument alone and let it run. And in today's market, where the laboratories have to be more and more efficient and use technicians for more and more purposes, this allows technicians plenty of time to do other tasks. This is just another way of looking at the same sort of thing where we're looking at the percent of time that people have that's walk-away time, and what you see in the lighter gray is the actual amount of hands-on time. And so you can see that it ranges from about 38% to 16% for the different assays. So with these new next-generation automated instruments, we now have the ability to screen more and more patients and yet not burden the lab horrifically. One thing to be aware of is space, the final frontier, as I like to say, and that's an age issue right there, isn't it? That they do take up different amounts of space, and not only is there the instrument footprint, but then there's also the workspace requirements for the bench space and the other storage issues and the other manipulation issues that you need for those different pieces of equipment. So it's something to take into account when we're making decisions about what type of assay we want to go to. So I just want to wrap this all up and leave some time in case there are questions, which I see the blinking light that there are questions. And my final thoughts here are that we really need laboratory options and clinical options that help us improve adherence to the screening guidelines, because we have the guidelines, we've had the guidelines for coming close to 15 years now, and we're really not doing that great of a job at adhering to them. And part of that I think we can move past because we now have these improved next generation NATs that actually can extend our ability. And I think, as I've already mentioned, one of the key features is that we can use self-obtained samples. But we can also use those self-obtained samples not only in clinics where it could improve clinic flow, but also in non-traditional settings. So I've used this sampling method for doing studies in bars, in bathhouses, for doing routine screening in detention centers, in school health clinics, etc. So when we think about asymptomatic diseases and trying to really improve our ability to cover those asymptomatic diseases, we need to be offering screening to people, not waiting for them to come to clinic, unless we can offer them in conjunction with other services, such as reproductive health care services for women. Extra-genital testing obviously can improve case finding in certain populations, and it's certainly worth considering, but it does require validation within each local laboratory. But the other thing is, I think that the excellent sensitivity and specificity of these assays really could encourage providers to offer tests to more patients, because they don't have to worry as much as they did 10, 15 years ago about the potential ramifications of a false positive result, and they don't have to worry about missed cases with false negative results. So all in all, I think that the next generation's NATs really offer us a lot of opportunities that can help us change our laboratory methods as well as our screening efforts, and hopefully then actually have a really profound impact on the rates of disease in the U.S. And with that, I'll thank you for your attention, and I will take any questions that you have. Okay, that will do it. Thank you. Oh, I do see that there is a question here. What measures should be carried out to make people visit the doctor at initial stages if they're suffering from an STD? And this is a really interesting question. The issue here is that most people don't know that they have an STD, and so obviously education and awareness so people do understand what the signs and symptoms are. All too often, for example, if a woman has a discharge, she may not know if it's an abnormal discharge or if it's normal. So that type of education, when women first engage in the reproductive health process, so when they first come of age and start perhaps using birth control pills or having Pap testing, they should be given information about what the possible signs and symptoms are. But so many people are asymptomatic that rather we need to say to people, this is something that you do every year, in the same way that you go and have your teeth cleaned every year. You don't wait for your teeth to tell you that they're dirty. You go to the dentist and have your teeth cleaned. So these are the types of things that we really need to think about in terms of how we educate the population. The biggest problem that we have right now is that isn't considered routine behavior, and so people think that it only happens when we have some sort of cause for concern, so some sort of sexual guilt or behavioral guilt where you think, oh, I've done something I shouldn't do and now I have to be tested. So until we can get away from that attitude and get to where it's a more normative behavior to have people be screened, then we won't have a great deal of success in curbing these infections. Thank you for your question. All right, I'd like to thank you for your attention, and I hope you enjoy the rest of the conference. Thank you very much.